Hi, welcome to the webinar today by PeerView. We will be talking about the role of PARP inhibitors in patients with metastatic castrate-resistant prostate cancer. And we will learn what VA can do better than us. So from Veteran Affairs Hospital, we have Dr. Martin Schoen. We will introduce ourselves in a moment. So let's look at our introduction. My name is Niraj Agarwal, Professor of Medicine, and I direct the Genitourinary Oncology Program at the Huntsman Cancer Institute, University of Utah in Salt Lake City. Marty?
Yes, thank you, Dr. Agarwal. I'm Marty Schoen. I'm in St. Louis, Missouri. I'm an assistant professor of medicine at St. Louis University, as well as a staff hematologist oncologist at the St. Louis Veteran Affairs Healthcare System. And I'm honored to be here to discuss this important topic, that affects care for, many men with prostate cancer.
Same here. Honored to be here with you and with everybody else. So this is the welcome note. So thank you to the PeerView and NavRef for providing this session and Pfizer for educational grant for this symposium. And please look for additional polling questions during the presentation. We'll be asking questions throughout. And please submit your questions during the Q&A session so that we can discuss. We can have a more lively, interactive discussion. So we are really looking forward to it. And of course, this is the PeerView website for this session. You can download the slides. These are very informative slides, and they can really help during the treatment discussions with the patients in the clinic. I use them all the time. So our goals are, we will like to discuss the evidence and rationale for PARP inhibitors in patients with metastatic CRPC. And we will discuss how we can make the integration of PARP inhibitor therapy into individualized care plans for patients with mCRPC. So how to utilize them in the clinic. I continue to learn over the last 10 years, right from starting from olaparib, post-chemotherapy, rucaparib, pre-chemotherapy, olaparib, and now we have so many doublets. So we will be discussing those recent evidence during this time with you. And then we will discuss some cases. So this is the first polling question. In your practice, which of the following represents a challenge to your decision-making for treatment of patients with prostate cancer? And of course, many of the colleagues are oncologists who are not specializing in prostate, kidney, and bladder. So we, of course, have different set of challenges. But please take this poll and select all that apply. We'll keep moving. So let's look at the current status of prostate cancer. We know this is one of the most common cancers in men, and overall incidence rates are very high. And this remains one of the common causes of cancer-related deaths. Every year, we lose more than 35,000 patients, men to prostate cancer, to mostly metastatic prostate cancer. The median age of diagnosis, as we all know, is 67, around 67, late 60s. And this is the overall schema of how these patients are presenting and how they present. Most of the patients present with localized cancers, some present with lymphadenopathy, so lymph nodes are enlarged. A small number of patients present with de novo metastasis, so they never had localized prostate cancer, and they present with metastatic prostate cancer. And of course, we don't know about 9% of these patients, but this is the ballpark of how prostate cancer patients are presenting to us. And we know lethal form of prostate cancer is metastatic prostate cancer, which is the focus of conversation today. This is a natural history of prostate cancer. To make it very simple, we start with androgen deprivation therapy plus androgen receptor pathway inhibitors. That is a new consensus name for NHTs, ARSI, next generation AR blockers. So we decided to come up with a consensus in the field. And this is the consensus, ARPI, androgen receptor pathway inhibitors. So enzalutamide, darolutamide, apalutamide, abiraterone, all of them are called as ARPI by us now. And of course, radiation therapy to the prostate has a role, even in the case of metastatic prostate cancer, if this is low volume disease. And then we know these therapies are approved, taxanes, radium, PSMA PET scan based therapy, which is lutetium therapy, and MSI high or TMB high prostate cancer patients can have pembrolizumab, and patients who have homologous recombination repair deficiency in their tumors, or even germline, they can get PARP inhibitors or platinum-based chemotherapy. These are the classes of drugs which are approved for mCRPC. And I really like this slide because this gives me a snapshot of overall survival benefit in each one of these trials. So if you look at the enzalutamide trial, median overall survival benefit was 5 months. And in those days, this is PREVAIL trial, patients who were progressing on ADT only during hormone-sensitive setting, they were randomized to enzalutamide versus placebo. And we saw a 5-month improvement in survival. The median overall survival with enzalutamide was 36 months. Surprisingly, we do not see many trials in first-line mCRPC breaching the 35, 36-month mark until very recently, and I will be coming to the trial of olaparib plus abiraterone and talazoparib plus enzalutamide. But unfortunately, we didn't see that 3-year mark being breached by any of these trials. And of course, some of these trials in later lines of therapies, but I'm just talking about the first-line therapy trial. So abiraterone, Cougar 302 trial, as we remember it long time ago, the median overall survival with abiraterone was 34 months in first-line mCRPC, 4-month survival benefit. And of course, trials which are run in the later line of therapies like cabazitaxel, 2.6-month survival benefit, lutetium PSMA, 4-month survival benefit, and look at enzalutamide talazoparib trial in metastatic hormone-sensitive metastatic CRPC patients with homologous recombination repair deficiency, 14-month improvement in survival. And patients who had got abiraterone plus olaparib in all-comer patient population, the trial did not look at positive or negative patients by HRR mutation positivity and negativity, 8-month survival benefit. So first time now we are seeing a breach of that 4-month, 5-month mark in terms of survival benefit. So before I move forward, we just discussed this. The real world median overall survival of patients with metastatic CRPC is less than 3 years. Consistently, there have been studies published based on real world data, patient level data, Flatiron data, or many other database. Is very similar to what we just saw in the context of Cougar 302 trial with abiraterone or PREVAIL trial with enzalutamide, both reported more than a decade ago. The median survival had not been breached. Survival of 3 years is consistently less than 3 years. But more importantly, half of our patients don't receive 2 lines of therapies in metastatic CRPC setting. And there are multiple studies. I just showed you at least 10 drugs approved in metastatic CRPC setting. And of course, there's some overlap in the mechanism of action, but there are at least 4 or 5 or 6 different mechanism of actions available. But our patients are getting only 1 systemic line of therapy, half of them, and half of them receive 2 lines of therapies. And there is a significant drop with each line of therapy, which basically tells us patients are older patients with this disease type. Once they have disease progression, they do not maintain their performance status to allow them to receive subsequent line of therapy. And hence, in my view, combination therapy works beyond the synergy, beyond the interactive cooperative nature of 2 different mechanism of actions. One reason combination therapy works, whether it is hormone sensitive metastatic prostate cancer setting or metastatic CRPC setting, is because patients get 2 therapies at the same time without having to worry about sequencing, because anytime we sequence, we lose half of these patients. With that, I'll hand over the mic to Marty, Dr. Schoen.
Great. Thank you, Dr. Agarwal. And I'd like to echo what he just presented. that data in the VA as well in the real world shows that most patients are not living beyond 3 years with MCRPC. And the VA is one of the largest healthcare organizations in the US. Over 9 million veterans receive healthcare from the VHA. And in the VHA, prostate cancer is the most common cancer diagnosis. And it's over 30% of cancer diagnoses every year. And that the burden of prostate cancer is substantial, with many, many survivors, but as well continuing new cases. And some of these cases are because of exposures that was received in the military, such as Agent Orange, and that patients who receive a prostate cancer diagnosis that were in Vietnam are presumed to have an Agent Orange related condition. And so these are important to think about as we talk about how to treat patients with MCRPC, because it's important to understand who the patient is as well as their genetics. So I'm going to move into the next sort of part of our slides to talk about the genomic testing and who's eligible for PARP inhibitors and MCRPC. So I'll start and do a little bit of a review. So cancer is a genetic disease. It results from DNA damage that occurs. And typically, DNA damage occurs every day. It occurs from exposures. It occurs from the food that we eat, the sun that we get, and typically our body is able to manage these DNA damage events, and we have multiple mechanisms to manage these DNA defects. The first is single-strand breaks that we see in the middle. One of the main enzymes or mechanisms that we have to repair single-strand breaks is the PARP, or poly-ADP ribose polymerase. The other main mechanism of repairing single-strand breaks or DNA damage is the BRCA methods, which is double-strand breaks. You can see that there are quite a few enzymes and proteins that are involved in repairing double-strand breaks. And because this system is so robust, it's something that we have to think about when we're treating cancer. And that in patients that have homologous recombination repair deficiency, which is unable to repair double-strand breaks, we can use things like PARP inhibitors, which is a mechanism of blocking single-strand breaks, to create what is called synthetic lethality. Because one mechanism of repairing is already not functional, we can inhibit the second mechanism, and that can kill cancer cells by disrupting DNA repair and survival, and go on and having cell death. So it's really important that we're harnessing these tools that are based off of genetic information. But we cannot harness these tools if we do not use the genetic information. And we really need to understand the genetic testing that is available. There are two major categories of genetic testing. There is the somatic as well as the germline. So somatic testing, which is somatic mutations, those occur in the tumor. And that we know that approximately 1/4 of tumors have some sort of DNA repair alteration. And as patients move along their cancer journey, the frequency of these DNA repair alterations increases in the tumor. As well, it is really important to know not just what's going on in the tumor, but what is going on in the patient. And there are germline mutations. These are things that the patient is born with. It's in their entire body. Things like BRCA mutations are well known from other cancers, such as breast cancer, and made famous by stars such as Angelina Jolie, who is public about her BRCA mutation and the choices that she made about her life. So these two pieces of information, the somatic testing and the germline testing, are essential for providing the best care for our patients. And so therefore, we have to be able to test for them. And current guidelines from ASCO, as well as the VA, recommend testing all patients with metastatic prostate cancer by both methods. We have to have genomic, which is the somatic testing of the tumor, as well as the germline testing. And that we recommend in the VA, as well as ASCO, it should be done with every patient with metastatic prostate cancer. And using the guidance from the VA or organizations such as ASCO or NCCN is really important in order to figure out these therapies. And it's really sometimes difficult to acquire tissue and to do this, in later lines. And so it's recommended that we do it upon metastatic diagnosis. Now, it can sometimes be a barrier to getting this testing, and that we know that testing is not happening at the rates we'd like it to occur. We look at the rate of the somatic testing, which is the NGS testing on the left over time in a population of patients in the Flatiron databases. We can see that testing has really only gone up to approximately 1/3 of patients, and that it is not reaching what we would expect, which would be at least close to 100%. And that it is an unfortunate thing, because if you don't test, you really don't know what is going on with the patient and their tumor, and then patients are unable to benefit from some of these more advanced therapies. This is also represented in the VA data. We are aware that even in the VA, that the testing has not reached some of the highest levels. It has been wonderful that over the last 8 years, that a collaboration between the Prostate Cancer Foundation as well as the VA has encouraged genetic testing, and a contract has been made available for all veterans to get genetic testing in the VA who have metastatic cancer. So it is a covered benefit that patients do not have to pay out of pocket for, and that we know that because of this benefit, we've been able to get more and more veterans tested. And starting in 2016, it was pretty close to 0. And then the most recent data is from 2021 that approximately 1/3 of patients were able to get testing. Hopefully it's increasing even further, but we want to highlight that there's still a gap in testing and that we need to be aware of. Now, there's been some discussion and some limitations that have prevented people possibly from getting tested. There are veterans that are concerned about their benefits, about their service connection, and that if they're found to have a germline alteration or a genetic alteration, that it may affect their benefits. Luckily, in the past several years, this has been something that has been brought up, and that therefore the Veteran Benefits Manual has been modified, that the results of genetic testing should not affect the benefit ascertainment or the determination of benefits for every veteran. And this is something really important to know, because there is sometimes misinformation that is out there. And so it is something that clinicians and people who want to be able to provide the best therapy should be aware of, to be able to highlight that benefits should not be affected by a germline testing alteration. So I really wanted to sort of open this up and discuss with Dr. Agarwal, what has been some of the best practices that he has seen, and what is the things that we can do to incorporate the testing, in our routine clinical care? How do we deal with some of the misconceptions or, information that may have been accurate before, but now is not currently accurate? And that, how do we really increase this ability to figure out exactly what's driving this tumor and provide the best therapy?
Thank you, Dr. Schoen. So I will make it very easy. The way I practice in my clinic, talk to my colleagues and my patients about this, I start with the number one reason for doing these tumor genomic testing. Even somebody is not very enthusiastic about germline testing to begin with. And of course, we don't have those genetic counselors in the clinic, but my team can order somatic testing right away in the clinic while they're in the clinic. So this is what I tell them. Number one, there's a 1/3 chance of you having a germline mutation or germline pathogenic variant if you have these somatic tumor mutations, example, BRCA1 and BRCA2. There's a 33% possibility that you are carrying a germline pathogenic variant, which can have devastating implications for your family members. And one of my 62-year-old men luckily had germline testing, and both daughters had BRCA2 mutations, and both survived because their dad had prostate cancer, endured metastatic prostate cancer, and was willing to do a germline testing. And this is a classic example. Devastating family effects on the family can be prevented by doing somatic testing followed by germline testing. But then you talk about prostate cancer, we have PARP inhibitors approved, oral pills, and we just saw the survival benefit in a snapshot, but we'll show you the survival benefits in a moment. These are oral pills, easy to manage side effects. With experience, of course, all of us need some experience. Most of you actually deal with more chemotherapies than we do mostly as geo-oncologists. But the bottom line is these are effective therapies. But beyond PARP inhibitors, beyond homologous recombination repair gene defects, there are other somatic mutations which may allow our patients to be candidates for pembrolizumab, which is so well tolerated. 3% patients have MSI high mutations, MSI high status. Another 2 or 3% patients of ours have TMB high status, and they have beautiful responses to pembrolizumab. And then lastly, within the PARP category, there are differential responses. So BRCA1, BRCA2 versus CDK12 versus patients who did not have any of these mutations. So that definitely comes into the play when we talk about treatment options which are available out there, and we'll be discussing this in a moment. But more importantly, the timing of testing. Dr. Schoen, Marty, you just brought this up. When we were doing the PROfound trial, which led to approval of olaparib, 30% of these patients were not even eligible for screening. So I knew they were otherwise eligible for the trial, but we did not have tissue to screen because the tissue had lost the quantity or quality by the time they reached castration-resistant stage or phase. So these tissue samples, they lose quantity and quality with time. I was not aware of it until I started ordering these tests. And anytime a test is more than 5 years old, it is more difficult for these companies, CLIA certified labs, to run a successful test on these. So instead of waiting for castration resistance setting, I'm actually ordering these tests, both germline testing and somatic testing, when I see the patients for the first time. And ASCO guidelines published on January 9th is actually helping me with insurance pre-authorization, because I just sent the guideline now, and it clearly says without any ambiguity that patients need to get both somatic and germline testing for metastatic prostate cancer, not metastatic castrate-resistant prostate cancer. So easy to get reimbursed. And now when I see a newly diagnosed metastatic prostate cancer patient, in addition to CT scans and bone scans, I order somatic testing and germline testing. And there are multiple CLIA certified labs such as Foundation Medicine, Caris, Tempus, and many others which are there in the field for a long time, which provide fantastic support from the testing perspective. So with that, anything, Marty, I missed discussing this?
Yeah, one thing I'd like to add is this is a wonderful benefit of the VA because of the NPOP contract. When I'm at the VA, I'm able to just click a few buttons and order genetic testing through an order set that is know that it would be reimbursed and performed. And the more important thing is that I have the discussion with my patient about what I'm doing and why. And that takes, is I think the important part. And at least in the VA, some of the burden related to reimbursement has been relieved or alleviated. So that's why I love working in the VA. But yes, back to you, Dr. Agarwal, to sort of talk about the benefit of these therapies.
Yeah. So order the test when we see the patients for the first time. I have learned that. Anytime my patient has metastatic prostate cancer, I order these tests. And even locally advanced, and we can discuss this later, but it's very easy to get those reimbursed nowadays. So we have another question. Please take a moment to answer this follow-up question about discussing the importance of biomarker testing with the patients. I guess there is no question here, but please put your questions in the chat box, or please speak up, let us know throughout the program. Doesn't matter if you are speaking or presenting the slides, please have a very low threshold to post your question in the chat box, or just pick up the mic and please speak up. So in the next few slides, we will be talking about the latest evidence for PARP inhibitor regimens for patients with metastatic castrate-resistant prostate cancer. Let's start with the monotherapies first. So we know olaparib was approved in 2019 for patients who had HRR gene mutated. So they had to have HRR gene mutations, metastatic castrate-resistant prostate cancer, who had progressed on a prior ARPI therapy, so enzalutamide or abiraterone. And I have patients who have progressed on apalutamide or darolutamide, even they are eligible. Rucaparib has a different label. Rucaparib is approved for patients who have received both an ARPI and taxane chemotherapy. So rucaparib is approved for a little later in the setting, but both are approved as monotherapy. If you look at the data of radiographic progression-free survival and overall survival, both are present. And we can see radiographic progression-free survival was improved by about 4 months with olaparib. And if you look at the overall survival, it was also improved with a 30% reduction in risk of death. So few months improvement in survival with olaparib monotherapy, and it didn't compromise quality of life, which we see with most of the cancer therapies, which are efficacious because effectiveness negate toxicity in general. Because by basically better control of the cancer, as we know, also reduce cancer-related side effects, which can be a lot of side effects. So that somehow negate the side effects of the drugs. If you look at rucaparib data, there was a radiographic progression-free survival benefit about 2 months. And we did not see any significant overall survival benefit. And rucaparib is approved after docetaxel chemotherapy and an ARPI in the mCRPC setting in patients who have BRCA1 and BRCA2 mutations. Now let's look at the combination therapy, which is the focus of this discussion today, because these data are new. And this is a nice picture, but the way I explain to my patients is that the PARP pathway, the DNA repair pathway, and the AR pathway talk to each other. So when we are assaulting the prostate cancer cells with ARPIs, the PARP comes to the rescue of the cancer cells by enhanced repair of the DNA. So if we block the PARP at the same time, along with when we are blocking the ARPI, that may lead to extension of benefit of these PARP inhibitors to not only those patients with homologous recombination repair gene mutations beyond BRCA1 and BRCA2, but also to those patients who do not have these known DNA repair mutations or homologous recombination repair gene mutations. So even I will show you the data in a moment, even patients who did not have these mutations seem to have benefit, although magnitude of benefit is much higher with BRCA1, BRCA2, followed by patients with HRR gene mutations, followed by patients who do not have HRR gene mutations. So there is a cooperativity between the two pathways, which lead to enhanced effect of each of these agents. And these are the FDA-approved PARP inhibitors, ARPI inhibitors combinations. The first one is olaparib plus abiraterone. It was approved based on PROPEL trial, and this is approved for BRCA1 and BRCA2 mutated patients. Niraparib and abiraterone, similar indication. And talazoparib plus enzalutamide are approved for patients who have homologous recombination repair gene mutations with mCRPC, so all HRR gene mutations. If you look at the data from the PROPEL trial, these are very similar trials as far as design, especially PROPEL and the TALAPRO-2. Obviously, these are different trials, but I'll talk about the PROPEL trial first. All comer patient population, they did not get tested before starting the trial treatment. They are all comer patients. Whoever was presenting to mCRPC with complete disregard to the presence or absence of HRR gene mutations, they were randomized to abiraterone versus abiraterone plus olaparib. And here we can see the radiographic progression-free survival is in the BRCA1 and BRCA2 mutated patients. We are talking about a hazard ratio of 0.23, 75% reduction in risk of progression or death in BRCA1 and BRCA2 positive patients. The overall survival benefit, again, quite significantly improved by adding olaparib to abiraterone. Now, if you look at the magnitude trial was different. The investigators predetermined who is positive, who is negative. The negative portion was terminated early based mostly on PSA progression because the trial did not show benefit with niraparib and abiraterone combination, but trial did show benefit in BRCA1 and BRCA2 positive patients. And we can see here there is about 9-month improvement in radiographic PFS in BRCA1 and BRCA2 mutations, not others. We are just talking BRCA1 and BRCA2 mutations because that's how the label is right now. Now, if you look at the TALAPRO-2 trial basically were 2 trials in one trial. We recruited 805 patients, all-comer patients. We didn't look at the testing results, but we did test everyone. And these are all-comer 805 patients. They were randomized to talazoparib plus enzalutamide versus enzalutamide plus placebo. And this is focusing on the HRR deficient population following the FDA label. We can see the difference in the progression-free survival. And this is quite telling that we have like about a remarkable improvement. I don't want to go through the numbers. You can look at the numbers. They are very straightforward. What the striking results are, the 14-month improvement in overall survival. If you look at enzalutamide only, 31-month overall survival, very similar to what we saw in the what you would expect in patients who have these homologous recombination repair mutations. So let me take a step back. Let's look at the radiographic PFS. So what was the radiographic progression-free survival in the PREVAIL trial with enzalutamide? It was 20 months. What is the rPFS in patients who have HRR gene mutations? 13 months or 12 months. That tells us the patients who have these mutations, they don't do well on standard of care treatments. But then you add talazoparib to that, we improve the PFS to 30 months. Similarly, overall survival benefit, 31 months to 45 months. When was the last time we saw this magnitude of overall survival benefit with any combinations? So this is quite striking as long as PFS and OS results are concerned. And that's why it is so important to test these patients. If you look at the HRR negative patients, so we decided to do this, show this slide as an example to show the cooperative nature of our AR pathway and the DNA repair pathway. If you look at the HRR, so this is HRR unselected patients, all-comer patient population, there was a 9-month improvement in overall survival, and there was a 14-month improvement in radiographic progression-free survival. This is all-comer patient population. And we don't have label for this. But just for the sake of discussion, because trial enrolled these patients, in first 805 patients, we are seeing a 14-month delay in radiographic PFS and a 9-month delay in the overall survival, or improvement of overall survival. And these are, again, quite striking results. Now, just for the sake of completeness, I would like to show you the slides on patients who did not have these HRR gene alterations. Doesn't mean we should not be testing them, because you can see very clearly that patients who had BRCA1 and BRCA2 mutations versus who had HRR gene alterations, we are talking about a much higher magnitude of overall survival benefit. But in patients who did not have any of these mutations, both by ctDNA and tumor tissue testing, so rigorous testing, no HRR gene alterations were detected, we still see the hazard ratio favoring the talazoparib arm, a 22% reduction in risk of death with a 9-month improvement in overall survival. So I think these data confirm that these patients benefit with the combination. And for the sake of time, I will not talk too much about the BRCA trial we recently reported. It was a small trial where patients were randomized to abiraterone versus olaparib versus abiraterone plus olaparib in the newly diagnosed mCRPC setting, and they were allowed to sequence. So when they sequence from when they got abiraterone first, they were able to sequence to olaparib. They got olaparib first, they were able to sequence to abiraterone. If you combine the PFS of sequencing, it was 16 months in the ABI followed by olaparib or olaparib followed by abiraterone. But if you look at the PFS with abiraterone plus olaparib, it was 39 months. And that trial, even the small trial, basically improved my confidence in upfront combination rather than sequencing. And by the way, when we were sequencing, we were not able to treat half of those patients, which is consistent with what we see in the real world. Just for the sake of discussion, there are two trials which will be reporting soon. And these trials are moving these combinations to upfront setting in the metastatic hormone sensitive prostate cancer setting. And that will give us one more reason to treat these patients with PARP inhibitors in upfront setting, assuming these trials are positive. But more importantly, these results, if they're positive, we will not have any reason to not sequence these patients in the metastatic hormone sensitive setting. So these trials are coming up. We'll be seeing these data very soon in the clinic. And I'm really hoping that both these trials are convincingly positive to improve the lives of our patients. And with that, I will ask you to please post your questions to your websites or ask any questions here. And while you are thinking about those questions, we'll keep moving on. So Dr. Schoen?
Thank you again, Dr. Agarwal. So, one of the most important things that we have to think about is, how do we actually use these drugs? Because while they may exist, if we're not able to deploy them, to actually, help a patient and do it effectively, nobody's going to get any benefit. And so it is important to know about the adverse events and how do we mitigate things like adverse events. And so that's what I'm going to talk about. So these are the most common adverse events with PARP inhibitors. We have the hematologic events of anemia, thrombocytopenia, and neutropenia, as well as some of the non-hematologic that are common, such as nausea, vomiting, diarrhea, constipation, and fatigue. Some of the other events that are rare are less common in our prostate cancer population, but can be seen in younger populations, that are treated for other diseases, but it is still something that might be possible. I'm going to highlight just a few of these to give strategies of how to manage these common adverse events. So the first one that is common is anemia. And so it's really important to understand how do you manage this? And so in patients that have just a mild decrease in their hemoglobin, that's actually relatively common, and as a grade 1, you really don't need to do any modification. You probably should consider, is the patient have the appropriate iron status, vitamins are appropriate, make sure that we're doing all the things that we always do for supportive care. When a patient has a larger drop in their hemoglobin down to grade 2, which would be a hemoglobin less than 10, but greater than 8, it is appropriate to interrupt the dose. And, depending on the patient, consider other things like a blood transfusion. But I would say that, these dose interruptions are common. They occurred frequently on clinical trials, and that a grade 2 dose interruption and a grade 2 event is not a reason to dose reduce immediately. Because a lot of times patients just need to adapt to this new environment, the PARP inhibitor, and so you can restart at the same dose. And so you don't necessarily have to do a dose reduction. When you get into a grade 3 or 4, which is someone who has an even lower hemoglobin that typically requires a transfusion or less than 8, dose interruption, of course, is appropriate. But at this point is when should consider a dose reduction, basically to manage this expected event. And again, this is common adverse. This is a common adverse event that we saw in trials, and so it's appropriate to be able to monitor it. And it doesn't mean that patients aren't having benefit from therapy, because it is something that we still saw that great magnitude of overall survival improvement that Dr. Agarwal highlighted in patients that in trials that had dose reductions. And that we also highlight what the dose reductions are for the different agents. And then you can consider whether or not this is the right therapy if it continues to be a problem. The other thing that I really wanted to highlight, which can limit patients' ability to tolerate these therapies, are the non-hematologic AEs. There is reasonable rates of nausea as well as dyspepsia or gastroesophageal reflux disease that can occur. And so it is important to consider administering an antiemetic, such as ondansetron or other agent of choice with each dose. And that it's better to do it approximately 30 minutes prior to dosing. You can also take the meds with food or eating smaller meals. Doing some of these things that we would consider doing in many of our other cancer therapies are appropriate for PARP inhibitors. As well, PARP inhibitors can be given in the morning or at night based off of patients' adverse events or their insomnia. And that it's important to be able to be flexible with these things. And it's more important to get the drug into the patient so that they can have the benefit as discussed. The last thing is fatigue. We know that patients have significant fatigue with prostate cancer, and that being able to manage fatigue is important. So that rating patients' fatigue, asking about what exercise they do, also what they're involved in, getting their partner a caregiver is incredibly important. And so I really want to highlight that this is something that is common, and with PARP inhibitors as well as other therapies, and to think about in order to get the benefit of therapy. So on that note, I'd like to sort of discuss a case that we can sort of think about how do we manage PARP inhibitors, as well as what situations might be useful. So this is a 67-year-old male, case of his name is Daniel, who presents with mild fatigue. He also had a sister with breast cancer. He was originally diagnosed because of the fatigue and elevated PSA, found to have Gleason 4+5 adenocarcinoma in 8 of 12 cores. Scanning was performed and found to have multiple pelvic and retroperitoneal lymph nodes that were above the aortic bifurcation, which means that patient did have distant disease, but it was lymph node only. It would be considered low volume, and therefore the patient was offered therapy with a combination therapy, but he declined an RP at that time, which sometimes people would consider for a low volume situation. He did well with the ADT up front, with the PSA reduction at 12 months was down to 0.4. Ideally, it would have been even a little lower, but he did have a PSA 90 response. Over time, though, the PSA rose, and at 2 years, the PSA went up to 16.5, and he noticed some pain in his back, and a new CT scan showed new bone lesions and progression of lymph nodes. So thinking about this case, we have several options to consider. Of course, I'd like to engage Dr. Agarwal in this case. When would we send for testing? I think both he and I would agree that at the initial diagnosis would have been a time to send for testing. Of course, I think we both would test for both germline and somatic. And then what in this situation, if the patient had a BRCA2 alteration, Dr. Agarwal, what would you think about doing for this patient who had progressive disease on ADT monotherapy?
Yeah, thank you, Marty. First of all, when do I do testing? Most likely, I would have tested this patient even before they developed castration-resistant disease.
Yes.
For the reasons I mentioned. Because tissue is fresh, tissue is more productive, more quality. I don't have to biopsy these patients again. For BRCA2 mutation positive mCRPC, we have 3 combinations approved in this setting. 2 are abiraterone based, so abiraterone plus olaparib, abiraterone plus niraparib, and then we have enzalutamide plus talazoparib, which is approved. And most of the time, my choice of therapy is driven by the underlying backbone ARPI. So if I'm starting enzalutamide, then I'll choose talazoparib. But if patient has, in patients with BRCA1 and BRCA2 mutations, and in patients who do not have BRCA1, BRCA2 mutations, as we can talk about the next case, we don't have any option but to go with enzalutamide with talazoparib.
Definitely. I think I share your perspective and would agree with that in this patient who's never had an RP, therefore would be a candidate for all of the many of the trials that you discussed. And as you mentioned, what we would do with a CDK12, which would be a non-BRCA HRR alterations. I think I share, as you highlighted, that in the CDK12, which was non-BRCA, we really actually don't have as many options. We have talazoparib plus enzalutamide, as the approval does include the non-BRCA alterations. And as well, we do know that CDK12 is one of the more sensitive alterations from some of our other analyses that have been formed. So definitely incorporation of something like a PARP inhibitor in this setting is essential.
Yeah.
Any other thoughts, sir?
I'd just like to add to the CDK12 mutation. Until very recently, based on the data from olaparib trial and the rucaparib trial, obviously rucaparib trial didn't look at the CDK12, but olaparib trial did. There was a consensus emerging in the field that CDK12 may not be responsive to PARP inhibitors. But then we saw surprising data from the randomized phase 3 TALAPRO-2 trial. The hazard ratio for RPFS was like almost 0.5, almost 50% reduction in risk of progression or death with CDK12 mutation. So definitely my viewpoints have changed. For patients who have CDK12 mutation, I actually encourage them to start treatment with enzalutamide plus talazoparib.
I completely agree. And there was a pooled patient analysis from the FDA that highlighted CDK12 as a sensitive alteration as well as PALB2. So definitely things to think about besides BRCA alterations that use of a PARP inhibitor might have some of the most robust data. And so as well, Dr. Agarwal, what would you consider if there was no HRR alterations detected?
Yeah, so according to the current availabilities, patients who have progressed on a single agent ADT or ADT plus bicalutamide, right now we have the option of starting them on enzalutamide versus abiraterone versus other approved drugs which are currently available are Sipuleucel-T, radium-223, and technically docetaxel chemotherapy, because docetaxel chemotherapy was approved in 2004 and we didn't have any ARPIs during that time. So in fact, docetaxel chemotherapy has never been shown to improve survival or outcomes after failure of an ARPI. So people ask me sometimes, oh, what is the data? How many patients who had in TALAPRO-2 or PROPEL trial who had prior ARPI? And I will bring up that discussion in a moment when we are discussing another case. But there are no data to show docetaxel is effective in terms of PFS or OS after ARPI failure. So, but ARPI, docetaxel is one of the options. So those are the options I currently discuss with my patients in the clinic. If we have approval by the FDA for Enza and Tala, then that may be an option down the line, but at least for now, we have all those approved options, which I love to talk to my patients about. Mostly asymptomatic patients, I go with ARPI in this setting.
I think that we share a similar approach. So I'm going to move on just a little bit more. So we kind of answered some of these already that, Daniel and his wife have questions about the impact of the new regimen. How do we talk through with it, talk it through with him and his wife. He did start on a PARP inhibitor combination, and he reported that he was feeling tired and his labs showed, mild anemia. What are some of the strategies that, you use, Dr. Agarwal? I know that we had discussed some of them, but, anything that you sort of would highlight, in this situation that you've probably encountered many times.
This is what I've learned in the last 4 or 5 years. If I'm starting somebody on any cancer therapy which is associated with anemia, it is a must for me to make sure they are not deficient in iron, vitamin B12, and folate. Because anemia can be so much worse with even chemotherapy. I'm not signaling out PARP inhibitors. In fact, pretty much all cancer therapies, whether you include radium, lutetium-based therapies, docetaxel, cabazitaxel, carboplatin, PARP inhibitors, all of them are associated with anemia. So I want to make sure they are not predisposed to have anemia. That's number one thing I do. Second, for the PARP inhibitors, specifically as far as anemia is concerned, incidentally, one of my colleagues in VA hospital asked me if they should start talazoparib at a lower dose to decrease the dose of anemia. Decrease the incidence of anemia. And I said no, because if you look at the TALAPRO-2 trial, half of the patients did not develop grade 3/4 anemia. And patients with most of these therapies, especially with PARP inhibitors, if they are going to develop anemia, they develop it early on, within 3 to 4 months. So I do monthly CBC, mostly local labs. I don't even have them come back here if they're on standard of care treatment. If I see a rapid decline in the hemoglobin, I don't necessarily wait for grade 3, 4 to happen. I preemptively reduce the dose. If somebody had a hemoglobin drop from 14 to 9, I know it is a matter of time before they reach a hemoglobin of 8 or less. So by the time I see a 2, 3, 4 points decline in a hemoglobin, I reduce the dose. And that was what was done in TALA-Pro 2 trial. Patient underwent dose reduction. They did not actually they were not required to have dose reduction until anemia was grade 3, 4, because dosing matters in PARP inhibitors. We cannot start with the low dose. And we will know who is going to develop grade 3, 4 anemia within 3, 4 months. And after that, we can decrease the dose. And once you decrease the dose, anemia rarely happens again. And these patients tolerate talazoparib pretty well, as evident by a 20-month duration of treatment of talazoparib. When was the last time we used a cancer treatment for 20 months beyond immune checkpoint inhibitors? Think about it, right? So I personally think patients' early management of these side effects, especially anemia or these cytopenias, can be easily managed with dose reduction. And once you reduce the dose, patients tolerate it very well. Thinking about fatigue, because we are also talking about enzalutamide or abiraterone, fatigue is best countered by exercise, in my view, in my experience. So we have actually formal exercise program and an exercise trial going on in Huntsman Cancer Hospital. But the number one treatment of fatigue is exercise, in my view. Of course, we can reduce the dose of enzalutamide, but then we reduce the potency or efficacy of enzalutamide or abiraterone. And that can lead to early disease progression, which can cause fatigue too. So exercise seems to be the best strategy. I do take breaks when the fatigue is excessive. I do decrease the dose, but as you said, Marty, many of these patients get used to the drug after 3, 4 months, and I'm often able to increase the dose to the baseline, to the starting dose. Anything else in the VA hospital?
Yes, we are blessed to be able to have people who focus on nutrition, or we have dietitians that are able to give some advice, as well as exercise programs. Frequently, the VA does have a program such as Move or physical therapy available. So there are definitely resources. These do tend to differ VA by VA, but I definitely refer my patients to these resources, and also to get that benefit, because it is such a multifactorial thing, and that being able to exercise and do the things you want really can help patients, both fatigue but just overall quality of life.
Yes. And nausea, vomiting is so common with olaparib and many cancer therapies. Why to single out one oral agent?
Right.
Most cancer therapies have nausea and vomiting associated with them. I don't send patients out without a prescription for anti-nausea medications, especially when I'm starting them on olaparib. Just talking about olaparib. But then niraparib has some unique side effects in addition, such as hypertension, and I make sure hypertension, being more common with ADT and enzalutamide and abiraterone, I tell them to monitor their blood pressure anyway. So adding niraparib actually doesn't add much to the hypertension. If you're talking about niraparib or monotherapy, that's a different thing, which we don't use now. There's no approval for that. But most of the hypertension fatigue is actually happening because of the androgen deprivation therapy component. And from that perspective, I tell them to monitor blood pressure regularly. And there's an increasing trend. We start them on lisinopril or amlodipine, the most commonly drug used in my clinic. But then primary care doctors do a fantastic job of doing that too.
Yeah, definitely. So I think we're on the fourth polling question, to take a moment to answer about this question about adverse event management. And I would
like to again talk about anemia for a second.
Yes.
So the three classes of, as you discussed, Marty, three classes of side effects. One is fatigue, which is most commonly associated with androgen deprivation, and then ARPIs, androgen receptor pathway inhibitor. And I cannot think of a better option than exercise to counter fatigue. That's number one. Number two is weight gain, which comes with fatigue and lower physical activity level. I tell my patients to decrease the portion size. I tell them that you are no longer going to need the same amount of food you needed before because your muscles are not burning as many calories. So if you don't decrease the portion size, regardless of the diet you are having, you are eating, of course, we need healthy diet and dietitians do a fantastic job. But any diet you are having, decrease the portion size by 30-40% at least. So these are the overall fatigue, weight gain sort of side effects, which are global. Then talk about nausea and vomiting, more organ-based side effects. I don't let anybody go home with anti-nausea prescriptions. So they go home with Compazine or Zofran, but depending upon the drug interactions and all that, I send them out with all those anti-nausea medications. Regarding cytopenias, I never reduce the drug dose upfront. Everybody starts with the highest dose or recommended dose of PARP inhibitors, especially in the context of talazoparib. Many of these patients have baseline anemia to begin with anyway. I monitor them with 1 month CPC. And I know usually, and most of my colleagues here are more experienced than me in using chemotherapy. We know within 2 or 3 months who is going to develop grade 3-4 anemia. And then reduce the dose when they are close to grade 3, and otherwise we compromise on the efficacy of the drug. And once we reduce the dose upon onset of grade 3-4 anemia, or even before when they're close, most patients tolerate talazoparib extremely well, or even for that matter, any PARP inhibitors. So slight dose reduction allow most patients to receive these PARP inhibitors at the optimal dose. So I just wanted to summarize the side effect control or management because that is so important for our patients.
Definitely. Yes, thank you. I think that it is, it's really important, to be able to, educate our patients. And this is our sort of final sort of slide before we go into our Q&A, that, the only reason why we have these wonderful therapies and that we are able to, benefit from the advancement of science is to enroll in clinical trials. And that, if we are not able to study the newest therapies, there will be delays for care and delays of advancement. We want our patients to be able to benefit from the newest developments in cancer care. And so we encourage everybody to think about, how can we get more patients to, benefit from clinical trials and advanced care? One of the ways, at least in the VA, that we've been doing that is by partnering with industry sponsors as well through our nonprofit corporations such as NAVREF. So NAVREF is the organization across the entire VA that helps to engage VA sites with research that is both industry and non-industry sponsored, and it's an essential partner in advancing care for patients with cancer. And specifically, patients with prostate cancer, we have a collaboration called the VA Precision Oncology Program for cancer of the for cancer of the prostate, otherwise known as PopCap, to be able to really bring the latest science as well as the advancements in precision oncology to patients in the VA. So I did want to highlight these, concepts that I think are essential for improving care for everybody.
And thank you very much. That was VA is doing such a fantastic job from that perspective with support of PCF and NAVREF, of course. I just want to answer one question by the audience. How did you make it operational to have this genomic testing in your clinic? What were the biggest obstacles? I think the nursing support staff, medical assistants are not used to doing that in those clinics who have never done it. So it is initially a learning experience, but the support service provided by most of the CLIA certified companies, especially important for smaller clinics, but we don't have the support of a cancer center. I never had to have I never had any problems because I had so much support in my clinic. But in smaller clinics, those CLIA certified labs provide fantastic support in my view. They can make it so easy to collect the samples and they can send the kits up front. And these, I won't single out anyone, but I have experience with Foundation Medicine, Caris, Tempus. Approach them and they will make it so easy for you and your staff. So I would approach them directly that you want to work, we want to send these patient samples. And after that, I think it is not that difficult once we start working with them. So thank you.
Right.
With that, I think it's time to finish this session. And I hope you like the session, like the information we shared and the discussions. So please complete your and submit your post-test session and evaluation for credit. And again, just to remind you, these slides are available for you to download and to show them to your patients and colleagues. So thank you very much for your kind attention today.
Thank you, everyone.